What would it feel like if you were shocked with a powerful electric current 70 times a minute through your chest while you're still wide awake? It would be torture, but that's what the doctors on the hit TV show The Pitt had to do to one of their patients. Watch till the end to find out why. I'm Dr. Sharky, I am a critical care doctor, and I'm going to break down episode 8 of The Pitt. If you're new, please subscribe and help grow our little community.
You guys a new rig?
Nah, we Ubered.
Willie Alexander, 81, near syncope from the Memory Day Center. They said he's more altered than usual.
Pulse is 30, BP's 80/40. No change with a mig of atropine. He's got a pacer in his chest, but there's no capture.
How you feeling, Mr. Alexander?
Call me Willie.
Okay, so we've got a gentleman who's got a very, very slow heart rate, and it looks like his blood pressure's dropping as well. And it looks like it's affecting his level of consciousness. He looks a bit drowsy. And they've given him a milligram of atropine, which is basically a drug that can sort of speed up your heart rate. We use it quite often, but it looks like he's not responded to it. So let's see what's going to happen.
I'm fine.
Any chest pain?
No, ma'am.
Do you take beta blockers?
I take walks.
Good question. So she's trying to find out what's causing his heart rate to slow down. Has he had a cardiac event like a heart attack? Do you have any chest pain? Do you take drugs like beta blockers, which are used to slow down the heart? Has he been taking any of them? Has he taken too many of them? Has he had an overdose of beta blockers? That's all relevant questions. Oh, okay, but looks like he's awake. It's always good the patient is awake. That means his heart is doing its job just enough to maintain perfusion to the brain, enough blood supply to the brain, so he's awake. So that's a good thing.
Every day.
Only med is Namenda.
On my count. 1, 2, 3.
Pacemaker patient with dementia. Heart rate of 30. Little altered with...
Okay, so we know he's got a pacemaker in. We don't know what it's for, but it's going to be because his heart rate is too slow. So it's got most probably an internal pacemaker, or what we call a permanent pacemaker, and that's going to help maintain his heart rate to keep his heart beating in a normal rhythm.
Systolic at 80.
What's your plan, Dr. Langdon?
Second mig of atropine now. Push dose epi 0.1 milligram portable chest.
31 on the monitor.
Ooh, so 31 on the monitor. That's pretty slow. So yeah, the plan sounds pretty sound. So they're going to give him another shot of atropine, some adrenaline as well. Sometimes you use a medication called isoprenaline and see if that helps as well. But usually the epinephrine works. It works for everything. Always carry a syringe of epinephrine around. Well, not all the time, but it's very useful.
31 on the monitor.
Dr. Javadi, what do you think of that heart rate?
It's not beta blockers, so junctional escape rhythm.
Well, that's good. So it's not beta blockers. That means it's not a drug overdose of the beta blocker medication. And she said it's a junctional escape rhythm. So the heart has its own conduction system, an electrical system that coordinates the beating of the different chambers of the heart. It'll start in what's called the SA node, or the sinoatrial node. So that's your master pacemaker that is in your heart. That'll initiate the electrical impulses that'll go down through the different parts of the conduction system and help your heart to contract in an orderly manner and with the proper rate. So if she said it's a junctional escape rhythm, that means the main pacemaker of the heart, the SA node, is not working. That's probably why this gentleman has a pacemaker put in the first place. It was probably not working for some reason. Probably what we call sick sinus syndrome. Can be due to many things. So what happens when the SA node stops working is that different parts further down the conduction system will take over, like the AV node, and then what we call the bundle, the right bundle, left bundle, the bundle of His. And so looks like the SA node's not working, and for some reason the pacemaker's not working either, the implanted pacemaker that this guy had inside. So let's see what they're going to do next.
Exactly, common with a non-functioning pacemaker. Etiology, Dr. Mohan?
Dead battery or lead failure?
Indeed.
Okay, so yeah, you want to know what the etiology is, what's causing the pacemaker to fail. Dead battery, always. Lead failure, so it's got sort of two wires going out into the heart from the pacemaker. Maybe one of the wires is displaced, one or both wires. Well, let's keep watching.
Good squeeze, even if it is slow.
Atropine and epi on board.
What's next, Dr. Lang? We can try percutaneous pacing, but eventually you'll need transvenous.
Ooh,
Systolic
ouch.
up to 95 with epi.
Okay, I think I heard him say they're going to try percutaneous pacing. That means they're going to put pads on the chest, and just like in a cardiac arrest, and they're going to try shooting electric currents to imitate the pacemaker that's inside. So, but that means the current has to go from the pads through the skin, through the subcutaneous tissue, through the muscle of his chest to the heart. So it's going to be a bigger sort of more power in the electrical impulses. And you can imagine getting shocked in your chest 60 to 70 times a minute. It's going to be painful. So I don't know. Let's have a look.
It's too low.
Let's start a drip, 2 mics per minute. Check the mental status.
He knows his name. Sir, do you know what year it is?
It's 20-something.
Do you know where you are?
It looks like a hospital to me.
Okay, so they're checking his mental state now to see if he's oriented in time and space. So the last question is like, where are you at now? Do you know where you're at? Do you know what time it is? Do you know what year it is?
Medical center.
Yep, I know this place. This Dr. Adamson's place. Where's he at? He working today?
So that's his doctor mentor friend, isn't he? Who saw during the COVID flashback in the last episode. I remember. Okay, ooh, that's he still hasn't gotten over the trauma from that. Look at his face. Oh, poor guy. Good acting.
Not shower.
What do you think, Dr. Duvati?
3rd degree. Complete heart block.
Because?
PV dissociation. No relationship between the P waves and the QRS complexes.
Good, they're looking through his ECG. He's got a proper, what we call a 12-lead ECG. It's not like what you get on the monitor. You can get it on the monitor as well. And they're going through, and they said he's got a 3rd degree heart block. That means his atria are beating independently of the ventricle. So the upper chambers of the heart are beating independently of the lower chambers of the heart. Usually they will beat in coordination. So you got a complete heart block. There's no coordination. And this is probably due to problems in the conduction system. Okay, let's see what they're going to do about it.
Clear.
Heart rate is 30. This low BP is going to make him a lot more confused.
Could cause a heart attack
Yep.
or a stroke if we don't fix it.
Well, mystery solved.
Let's have a look. Okay, nice. So that's the portable chest X-ray that they've taken. There's a pacemaker, cool. And like I said, there's the 2 wires, and you can see it's very clear. They're not connected to the pacemaker itself. So that's probably what's causing his pacemaker to stop working. But anyway, mystery solved, I think. Let's see.
Touching.
Totally disconnected. Shit happens.
Yeah,
Heart rate still in low 30s. No change.
shit happens indeed.
Pacing pads are on.
We can try.
Oh, that's right. Okay,
Willie. Your
pacing pads are on. I don't know what this is. This is not something we would do unless they were very compromised in terms of blood pressure and heart rate. And usually they'll be unconscious if I had to go for an external pacing, because it's very, very painful. I haven't had it done on myself personally, but I've seen it on patients who are semi-awake, and it jolts them. And it's like being burnt and shocked at the same time, apparently. So I would give them some pain relief, a bit of sedation maybe, but even then that would sort of drop your blood pressure further. The only time I really do this on patients on the intensive care who need temporary pacing and who are asleep, intubated, ventilated. I do it then. But here, I don't know, maybe they got some more options. And yeah, putting a temporary pacemaker is one of those options. Putting a wire into his heart through his peripheral blood vessels is a better option than shocking him through his chest. But okay, but we'll see. We'll see how he does.
pacemaker isn't working.
We gotta fix it.
We're going to try to pace your heart from the outside. You might feel it in your chest. Let's start at 10 mil.
You might feel it in your chest. You might feel it in your chest. Yeah, you're going to really feel it in your chest, buddy. Langdon, you should probably do it to yourself and see how it feels.
Oh, twitch it.
Oh,
No capture.
no capture. So he's just twitching. So they probably start on a very small sort of, and there's no capture. We're looking for capture beats. where the impulse from the pacemaker is captured and it's reflected in the ECG, in the EKG, as a contraction of the heart.
Increase to 20 milliamps.
That's more like a shot.
Up to 30.
Oh, y'all trying to electrocute
Pacer off.
me?
Damn right they're trying to electrocute you, my friend. Langdon's an asshole.
Tolerate it.
Get rid of this shit.
Dr. Langdon?
Dr. Landon, you're an asshole. Please stop that.
Verse said, can we set up for transvenous?
I was set up before you got here.
Transvenous pacing, so that's what we're talking about.
We need to float a temporary pacemaker from your neck into your heart.
Where is that?
Because your heart rate is only 30.
And hit me with a shot of atropine.
You've already had 3. Wait, are you a doctor?
He's out.
Oh, I hate that shrug. I don't know. I don't care. Your problem. Yeah, it's always the senior attending who does that is a dick. Never mind.
20 centimeters clears the cordis. Pacing box rate of 85 milliamps.
Confirmed.
Cool. So they're gonna essentially put a line through his jugular vein into his heart, and it's gonna be a wire. And they've got a pacing box there. That's your control unit, and it will generate the current and pace the patient.
On ventricular setting.
Passing to 30 just outside the heart.
Why do we inflate the balloon now?
So it'll float into the right ventricle.
Exactly. We're looking for...
An injury pattern since it's below the AV node.
Looking good. Check the
There we go.
pulse.
That's a good capture rhythm.
Strong radio, really strong.
Man, I feel like I just woke up.
Nice.
Yeah, that's because you did.
It's up to 130. How do you feel?
Yeah, like $1 million. White and QRS on the scope.
Willie, did you used to work at this hospital?
Hell no. I just brought the mail.
Can we still Giovanni?
Absolutely.
Time to shine, Crash.
Do you have time to write the procedure note?
No problem.
I'll be at Central if you need me.
Oh, geez, I still need to tell Nandi about her mercury level.
The average emergency doctor gets pulled from task A to task B every 3 to 5 minutes.
Remind me again why we picked this specialty?
Because we all have ADHD and anything else would be boring as hell.
No, I think we got OCD, which is good, but not ADHD.